Hello and welcome to another Pilates Hour, the Polestar Pilates Hour. We have returned with our two special guests, Shelly Power, Vice President of Polestar Education International, and Nichole Anderson, who is our Director of Curriculum and runs a lot of our platform development that a lot of you have become very keen on. And we're going to continue our conversation about sharpening our saw, basically our teaching skills. We're sure glad to have everybody on with us today. I mentioned that it's going to be a little bit of accountability today. So those of you that were with us last week, and Nichole and Shelly and I were discussing teaching skills, we're going to continue to do so. But I'm going to turn a little bit of the time over to Shelly to ask and see if you guys did your homework or not. So Shelly, you want to follow up on that?
Always me being the bad guy, checking on the homework.
Check-offs, exams. It's a bummer life, I know.
So I was just curious, for those of you that were in the webinar yesterday or last week, or if you've done this, just happen to have done this recently or done it as a student, we asked, as we were talking about teaching skills, we suggested that you audio tape yourself or videotape yourself to really hear what you are saying. So when you're teaching, sometimes you're not aware of the things that you say that are maybe repeated phrases. And now I'd like you to put your feet on the bar, and now I would like you to press back, and now I would like you to do this and that. Those repeated phrases that just happen over and over and over, or any other words, or chances for you to be just make improvements in your teaching. Some things that you noticed. I see Marianne wrote in, say perfect. She says perfect often, and you are the best. And one more time. So things that I've said many times myself. Maybe while we're waiting for people to put that in, Brent or Nichole could share some of theirs and some, ones that we've worked on over the years. I can tell the Bill story, Brent, if you want.
Yeah, that's a good one.
Yeah, we had a client years and years ago in California who worked for Toastmasters, and the studio, Brent's physical therapy clinic, was a long building. So it was a long rectangular building, and the reception was at the front and the gym was at the back. And we would come in and say, hey, Bill, great to see you. Go ahead and go back. And you've heard us tell this story probably before. And he stopped one day and he says, okay, do you want me to go ahead or do you want me to go back? Just make a decision. I can do either, but I can't do both at the same time. And it was one of the first times that I ever thought, wow, I did say that. And it was crazy. I'd never heard myself say that before. So I made it a point to, do my best most of the time to say, go back to the gym, please, and not go ahead and go back.
Yeah, I see some good ones coming up here. So now we're gonna, Nichole, did you think of any?
My big one, I find myself saying, we'll do 3 more of these. And I always say 3 more. And so sometimes if I'm really focused, I'll try and mix it up, and then 1 more, 2 more. I know it sounds so stupid, but I'll realize I've done it 4 exercises in a row, and it feels very redundant. Or I'll just wait and say, and that's it.
But that's not the nice thing about saying 3 more. And I do the same thing, and it's never 3. It could be 7, it could be 2. But I say 3 more so that I don't have to keep counting. I can focus on delivering a meaningful cue.
I do it because I think they start to get maybe an anxiety about how long am I going to be here? Because I'm trying to capture them before they say, how many more of these am I doing? So trying to preempt that.
I'm looking at one of the comments. I like 3 more better than 4 more. I was going to get a t-shirt saying 4 more. That's
so funny.
That is good. I would love to see a t-shirt like that. So I'll buy one.
Funny phrases that we all say. And I just want to put out there too that it's not that we're never going to say these things. I find myself saying which I get on other people about, well, it was like this and it was like that. Well, was it like it or was it that it? And so but I still find myself saying and so it's also to just put a little calm into it, is you will say these things. You will say or you will say, if you speak Spanish, you'll say entonces. You'll have those phrases in there. So it's not to get rid of them completely. It's just to be aware. Could you say something else? Like Brent said, could you say something else that is more meaningful at that moment? And sometimes you can't. So you just got to say 2 more, 3 more, and then get back on track with it.
And it's pacing, and it's pause, and it's space. And today we're actually going to spend some time talking about communications and communications between each other as practitioners. So how does Nichole and Shelly communicate to each other if they see the same patient or client? How do we communicate with clients? How do we communicate with their doctors? How do we safely talk about things that maybe without being offensive, or without maybe talking poorly about the physician themselves, or saying something negative about the healthcare practitioner, even though we might not agree with their position, or we make the assumption that they really don't understand Pilates, so for them to make a decision regarding Pilates isn't right. So how do we navigate that arena? And then we'll finish up today with what we had on our agenda last week, which is we'll look for a pathology of choice, and we'll talk about some cueing and some combinations of tactile and imagery and things like that can help us navigate desired outcomes. I think that's really the issue here. I think sometimes we get so caught up on trying to memorize the proper term or what always works for everybody. There's nothing that always works for anybody. There's no perfect image. There's no perfect tactile cue for everybody. There can be for an individual. And I think we need to be thinking, what is the individual experiencing when we give them these verbal and tactile cues? That becomes the most important thing. So I'd like to just reiterate the importance of always refining our communication skills. And as Shelly said, when I listen to myself teach, to me, it's always the most nauseating thing in the world. I don't like listening to myself teach. I know that I have some good teaching skills, and I work on them all the time. And it's important that I listen to them. And I also always seek feedback. Like this morning, I taught a class of 55 virtual at a physical therapy program to do their first Pilates class. So again, I usually like to do that live and give them a taste of Pilates, but we've been doing it for so long, it becomes sort of natural. And what I found so interesting was getting their feedback of things they noticed that worked for them in the class as novices. And I think that's where I put most of my emphasis, is listening to what they tell me. I ask what worked, what didn't work. What images did you appreciate? What did you observe about my teaching skills? And when they come back and reiterate what I wanted to get out of that, then I know I'm on track. If they come back and they say, well, you use this one cue that didn't make any sense to me at all, what were you trying to say with that? And then I have to go back in and reprogram, not get offended, but get reprogramming and think of what would be a better way or another way to say that, and even asking them, what would influence you to have this response? So that's sort of, going there now is thinking like, okay, let's talk about this communication process that we all have to do. So Shelly, you want to start off maybe I know you've got a number of items that are sort of in communication, especially as it pertains to our Polestar education.
Sure. Well, I'm just really glad that you brought up asking them not only what did you observe from it, what did you notice, what things work, but what would you have said differently? Because I think that's so powerful, and especially because you're working with the future physical therapists of the world, really, because we're so we have so much international contact with people, is putting them not on the spot in a way of tell me right now, but giving them an opportunity to think about it. It's like, wow, how would I describe that? How would I say that? Or what's meaningful to me? And it's important to hear all of those, and it educates us as teachers, because now I have 4 or 5 more new cues that I'd never even thought of before. And I think it's also important to do that culturally too, because what things are meaningful or important in a certain country or a certain place of the world might be different somewhere else. So I think that's really good. I think we can learn. And like you said, don't be offended, just learn from it. So I think that's great. So
the third sutra of the heart chakra is laughing, that Deepak Chopra defined as don't be easily offended. Like,
yeah.
just don't take yourself so serious. It's like we try to be the teacher and we're going to make mistakes.
I make mistakes all the time.
I want to give Nichole a prep because I'm going to ask, and I'm going to brag a little bit here because I do get a little bit of bragging rights and it might embarrass her a little bit. Some people know that Nichole is our oldest daughter, Lizette, my oldest daughter, but I don't really take credit for her great teaching. But I get comments all the time from people around the world that have taken courses from Nichole that don't know that she's my daughter, and have given great kudos as to how articulate she is in her teaching. And I sort of want to throw it back at Nichole too. I want her to be on because a lot of her teaching is virtual now. So she's teaching the virtual mat and the reformer with Shelly, and navigating that space of teaching novices to do Pilates through virtual platforms. We're all doing it now, but teaching a novice from an educational standpoint how to use and communicate with clients through the Zoom screen, through the mat screen. So you can think about it for a second while Shelly continues on her thing, but I just wanted to give you a heads up that I didn't want to drop a bomb on you all of a sudden. So. And I am very proud of her. She's a beautiful teacher. And again, she's had Shelly coaching her and Donna Wayburn coaching her and many of the other licensees, and Amy Brokemeyer out of Utah. She's had some great mentors over the last 15, 20 years, and is a beautiful teacher. So proud of her.
Yeah, agreed. So I thought we could maybe start. One of the things that we had talked about, Brent, was the communication with our clients when they are answering the questions, which we talk a lot about in doing the screening and the health history of our clients. And some people say, well, why do you do that? And well, I think it's incredibly important to get to know them. What are their desires? What do they want to do? What do they like to do? What is their past exercise history look like? What sports do they do? What injuries or surgeries have they had? And I think that process is really important, just from a rapport. I might even not take a lot of that information and deal with it, but I think in building rapport, I think there's a certain amount of trust that is, that occurs when that happens. And then what often happens, and you can speak to it from the physical therapist side, because I have a little different relationship to it. I went to the doctor and I have this pathology, and my doctor said I can't do X. All right. I have a disc pathology, and my doctor said I can never do flexion. And I'm thinking to myself, okay. Many people have disc pathologies and do flexion all the time. So I know there is not a direct correlation between having a disc pathology and always having, a problem doing flexion. So I know that, but in the background, I'm kind of, formulating that plan. And then what I want to know is maybe this person is unique. Maybe they really do have a problem with flexion. And I need to know why and how I'm going to go forward. So I often say, so what is it about flexion that is bothersome, or why did your doctor say that you can't do any flexion? And I would say, I don't know that I've ever gotten a reason why. I almost always get, I don't know, they didn't really say. And I think, wow, what an interesting, if somebody said, don't do something, wouldn't you want to know why? For a lot of different reasons. What?
Not if we're told not to do something by someone in authority.
True. So I start the conversation in the most respectful way that I can. I certainly can't say, well, your doctor doesn't know what he's talking about, and he just said that so you'd leave his office. Even though sometimes I know that's what happens, mostly, and no discredit to the physicians, but they're super busy and they don't have time to describe why your particular disc pathology might be bothered by poorly done flexion versus well done flexion with, all of our principles in place. They don't have time. So it's just easier to say, yeah, flexion bothers you, don't do flexion. So in the most respectful way I can, I want to start the conversation. It's like, well, I'm really curious why, so that I can tailor this movement session to you. And would you mind asking your doctor, if there's some reason why, something I should know, because there might be something I'm not aware of at all. And if I just go off of, well, we've done flexion with people before that have disc pathologies, it's going to be fine. That's an error on my part. That's not okay for me to make that assumption, because I don't have any way of knowing whether it is or not. So that was just something I thought of as we were talking last week, of making sure that we're really asking the questions of our clients to get the most information that we can. And luckily, I have Brent to fall back on, and I'll go to Brent and say, well, this is what this client told me. What do you think? And then he can give his more educated guess on what it is. But ultimately, it's back to the physician. Well,
Yeah, I mean, I think that's the key point here, is we don't want to disrespect the referring physician. We want to educate them and communicate with them and respect them in front of the patient, especially, right? So any kind of negative language about their referring practitioner is basically shooting ourselves in the foot. And so it becomes a diplomatic adventure, right? So the way that we work around that, as Shelly said, is seeking to understand more, seeking to understand what are the real aspects of this. And I think this is a really important point. When we go into our meaningful feedback loops, and I'll let Nichole and Shelly talk a little bit more about that. But one of the main things we're looking for is to get away from the very superficial language of I can't do that, or it's good, or it looked great, that was awesome, that was amazing, there are a lot of things missing, right? That kind of feedback is so superficial. It doesn't mean anything to the person receiving the feedback. And you typically have to go down 2 or 3 layers. And one instance I remember, Shelly and I were in Australia, in Perth, and we were doing an educator training, and we had a group of 4 over on the trapeze table, and we were practicing the meaningful feedback loop with our educators, because it's a very important part of our education delivery system. And one of the educators said, I really appreciated how you incorporated the principle of axial elongation. He used all the buzzwords, right? It was like, wow, great buzzwords. And then I looked and I said, what did you appreciate about it? And it was a quadruped exercise on the trapeze table that I think was leading into, I think it was a kneeling cat or something like that, the tower bar. But the point is trying to optimize their position as they were moving into that exercise. And so we asked the question, what was it that you appreciated about that? And he said something, I can't remember exactly what it was, but it wasn't at all what I was thinking of. Even though the buzzword was right, the explanation of what he saw that made him think that that was axial elongation at its finest was not what I saw, that I thought was a good representation of axial elongation as well. And then as we drilled down a little bit further, he was able to really articulate it in a way, and came back afterwards and said, that was so helpful to me, because I was able to drill down and keep asking myself, what of axial elongation did I see? He was looking at the lower rib cage, and I was looking at the relationship between the pelvis and the head. But it was totally legitimate. It was perfect, because the reality is, if you're thinking of axial elongating in a quadruped position, you're probably going to see the ribs narrow a little bit and come up from sagging down a little bit to be able to create that axial length. But that's what he saw, and it was different than what I saw. And I think that's a good place for us to start, of thinking like, how do we drill down? What are the things that you're seeing out there in the education world, the two of you, that tell us how important it is that we go beyond that superficial 1 or 2 layers of feedback?
One thing that we started doing in our mat trainings, or at least I started doing it in my last one, we kind of added this extra session because we realized we needed some extra time, and it was kind of a study session. And I posed that maybe instead of letting the one person teach and then do the whole feedback loop afterwards, that they were incredibly vocal throughout. So if the teacher gave a cue, if you didn't understand it, in that moment, say, I don't really understand what you mean here. And then for the teacher to say, what's unclear? Tell me what you don't understand. We're doing lots of inversions. This was in Mat 2. And it's really tricky to teach those things like corkscrew. It's like, move your legs behind you to the right over your head. It's like, where am I going? Towards a wall? Am I going over my shoulder? What's happening here? And so there's so much miscommunication, and it's really easy in the trainings for, in a training setting, or probably in a group class too, for people just to kind of muddle through and not ask a question because it's not really the environment, especially in a group class. So I've been thinking about, how do I bring that into my, actual clients, where they can really ask me if they don't understand. Now, one thing about private sessions is that if you're really paying attention to your clients, you can tell if they don't understand because they're obviously not doing something right. So that's really easy to discern. But for teaching, especially when you're teaching peers or things like that, where they kind of know the exercise, you don't know if your cue is sticking or not because they might be thinking of their own thing internally. And so you don't get that feedback. And so I think that was something I was seeing a lot in the trainings, that the student was just doing the exercise because they know it from watching the videos or from practicing it with their own teachers, and they weren't getting the feedback. It's so hard to just do what your teacher tells you only, so that they can know if their cues are sticking if you're not just a regular client. So really trying to have that communication between the students. And that group did such a better job in their checkoffs than my previous groups. I could tell that they understood it better, and they all learned it better in their bodies because everyone had different feedback about it. One person said, well, to me, I was thinking this, and if you had cued this, I would have understood. And the other person was thinking, oh yeah, that really worked. That makes more sense because I was struggling with corkscrew from when Nichole taught it to me. Whatever I said didn't stick with that client, but after that dialogue as them as students, it kind of all stuck.
Yeah, I remember, and I'm glad you mentioned this because I wasn't thinking about it. In the in-person mat, years and years ago, as the educator, we would have to take the role of a student in the class, and then one of the students from the class would teach an exercise, and I would do, short of just being a total jerk in the class, I would do what they said. And so if we think this was mat, but you could think about it, a common 2 reformer exercises: short spine, long spine. Short spine rolls over, long spine rolls up. Okay. And if somebody was teaching short spine and they said roll up, I would roll up into a tall shoulder stand. And then they would come over and they'd say no, because I was doing it wrong, even though I did exactly what they said to do. And then they would fix it and go on. And that was one of the early moments that I remember having this thought of, I've got to be really clear and true to my word of what I want. If I want up, I don't say over. If I want this, I don't say that. And being really, really clear with that. So that, I'm so happy you said that, Nichole, because it made me think of that. And they'd sometimes get so frustrated. I'm like, stop doing that. I'm like, well, then stop saying that because you're telling me what to do. And I am listening and doing what you said. And it also gave the students that moment of, wow, I'm actually in a place of power here. I'm responsible for everybody in this group. And I've got a big responsibility of, of really saying what I mean. Even, again, we all make mistakes and we all say the wrong things, and it doesn't matter. It's the 80-20 rule. But
well, it drives back
clear.
the message of external feedback to create internal feedback. If we're only creating external feedback from our verbal cues, our images, our tactile cueing, and we're not asking for the internal feedback and interpretation, then we really don't know. I mean, we can watch them do things, but are they doing it from a place that makes the most sense? Do they capture ownership of that movement? Especially if you are an educator. Many of you that are on here, I know educators around the world, and whether it's Polestar or other schools, you're educating other teachers in Pilates. How do we sharpen our skills of getting the most out of our students? I go back to when Shelly and I developed the immersion program, the gateway program, and we thought, how are we going to do this? We take, 2 months before we really are allowing people to be teaching Pilates, going through their mat training in the past. And we're saying that we're going to have them ready to teach something at some level by the 2nd day. And the whole course for immersion that we do with our physical therapists and universities is built around an immersion in feedback loops. So it's like, it's all experiential. And the first thing they learn is that feedback loop. And when they start articulating what they're seeing, feeling, asking, I love what Nichole just mentioned. I'm going to try that on the next one. It's amazing at how fast they synthesize the material from the inside out. And there's like this sort of thing going on between a conscious recognition or gestalt of the movement and a proprioceptive interpretation of that movement going on at the same time. Because you need to articulate. I think it's much scarier to have to articulate what your feedback is than it is to teach the exercise. If you're really taking it serious, you know, what did you feel? What did you observe in my teaching? You can't be absent-minded during that class if you're responsible to come back with feedback of what you felt and how you interpret it. There's one thing what we feel, but how you interpret it in language, that's difficult. That's a challenge. I do that with my PT students in some of their practical skills, and it's very difficult for them to articulate what the difference between, for example, a grade 4 and a grade 3 mobilization are. It's very difficult. And that difficulty is learning. That struggle is a learning. When you create that bucket, and this is true, we've talked about sort of teaching our clients, teaching other teachers, communicating with fellow practitioners, even with physicians. I think that it's this process of really being the seeker of understanding through our questioning, whether we're the teacher or the practitioner or the doctor's referring somebody to us, be able to ask those questions. Very powerful. Any other thoughts you have on that communication that you want to share today before we go into the next topic?
Well,
Yeah.
I like what Sarah's writing, talking about utilizing visualization and some concepts from the Franklin method. I think that's really valuable. I think that's one reason why we have one of his books, is it Dynamic Alignment Through Imagery, as one of our books for the students, just as a kind of baseline to see how your language can affect quality, especially. I think I see that more as a quality usage. And the other thing I wanted to add is that I think one of the big challenges is to allow people to learn. So giving them the space, whether you're working with your clients to take your hands off of them long enough for them to feel it in their own bodies, or if you're teaching students, and this is what I struggle with, I'm always running, so like, just shut up, Nichole. Stop talking, let them teach each other and come back with questions, ask them questions instead of just giving information. It's so easy to be like, I want to share all this stuff, I'm going to tell them all these things, and they're probably just like flatlining because it's too much information, versus when you're asking questions and they're put on the spot to have to answer, that it becomes much faster for them to actually integrate the material. And probably the same with clients.
Totally. And I agree with that in the sense that a lot of new teachers, a lot of, experienced teachers too, think that as teachers, our self-worth or our effectiveness is whether the client can do these things or not, or a group of people can do them or not. And in one way it is, if you're clear with what you want, your intention, your cues, you go through this feedback in whatever way is appropriate for the group you're working with. Yeah, you can see that the group is progressing and moving along. That said, when you're teaching somebody and they're just not getting it, they may just not be getting it and they need more time. And so, the old style of, do it right or do it wrong, or, do all these things of very black and white. It's sometimes it's just the way you do it. And one of the things I've been focusing on in my classes, especially because I'm back to teaching a virtual class for clients at our studio, plus individuals from all over the place join the mat class, is really making sure that they know that things like balancing or control, you need to be a little bit out of control to be in balance or have control. So it's like standing on the subway or on a train. If you're rigid, you're going to fall over. And so I expect that every time I do a movement or you do a movement, that the first one is going to be a little bit wonky, right? Side kick. How many times do you, okay, get ready for side kick and you bring your leg to the front and it's absolutely perfect? Never. Something is going to change. You're going to move in your body, your hips, something's going to change. And that's great because that tells me that your nervous system is going, whoa, I didn't expect that. Let's figure out how to do this. And then be seeking improvement with each one. If by the 10th repetition you're still doing that, then we may have to talk. But in the beginning, it's good to be a little bit off balance because it gives you an opportunity to refine what you're doing. And I think that's really important because sometimes the new student teachers, it's like, this has to be, perfect. And like, oh my gosh, no. I don't want anybody to, necessarily give me feedback on my first repetition of anything because I'm still figuring it out for that day.
And it's bring up an interesting point of the learning curve, right? The novice to expert that we talk about a lot in Polestar. And I do want to bring up a couple things that I know. Let's see, who was it that brought it up? I think in the chat, it was Sarah Edwards brought it up. We have been so blessed by so many great communication practitioners that we have incorporated into our training from, Carol Davis and Eric Franklin and Alistair Greetham and Helen Mason, and many people who have taught us things from neurolinguistics to community and diversity and age diversity and different levels of communication, how to communicate movement versus how to communicate instructions. And all of these things we've tried to build into our curriculum. And sometimes we take it for granted that we assume everybody understands that. And I think that's why we're here today, is to say, this is not common practice. When I go listen to other people teaching, sometimes I bite my tongue and I think that, okay, they have not had the advantage of an Eric Franklin, a Carol Davis, and Alistair Greetham, and some of the people that have really influenced our language of articulating what we want to see and asking the right questions for them to discover what they need to feel, what they need to know about themselves. And it's just a powerful part of our business. And I always joke about it, but it's, communication. I tell my physical therapy students, communication is 90% of our business. You can have the best movement skills, the best manual therapy skills, the best diagnostic skills. And if we don't communicate well, it's all worthless. And I think that's sometimes when our ego gets in the way. I've certainly been guilty of that. The ego gets strong, and this is the way you need to do it. This is the way it's taught. This is how you're going to do it. And it's like, it doesn't have to be that way. And the diversity amongst the bodies that we work with is so great. And we're going to talk a little bit about this right now, moving into the next part. But the diversity of the bodies we work with is so diverse that to assume that we could use the same visual and verbal and imagery cues that work with one group of population is not a legitimate assumption. It doesn't work that way. And so the more expert teacher is always seeking to understand if their communication is working, both in what the client says and what the client doesn't say. It's also in the movement assessment. We sharpen our eye, we fake it till we make it, right? We keep looking for those things to happen. I want to move into an area, and this is also part of communication. It's tied into things like words that we use commonly in the Pilates and movement instruction. Today, one of the things the students were aware of at the end of the class, and I didn't prep them on this at all, as their first class, and they said, you never told us to contract a muscle. In the whole hour and 15-minute class, you never mentioned hold, squeeze, tighten, pull, any of the verbiage or verbs that are about contracting. So I want to go there a little bit, and we can make it easiest by talking about the abdominal wall and the trunk, because that's an area where the glute squeezes, inner thigh squeezes, pulling the belly to the spine. I want to make it clear that we want all of those muscles to work. We're not saying don't use your muscles. We're saying let's create better cueing and communication to facilitate more spontaneous organization. So humans are built off of task-oriented movement. What's the activity you want to do? So I want to turn time back over to Nichole and Shelly to talk a little bit about how do you get around those words? That's the most common question that I get is how do you teach somebody when their belly's hanging out or their back's in, in anterior tilt and their sway back and you want to correct it. And the first place we go to because of history is pull that belly in or tighten that gut or hollow the abdominal. And there's a lot of resistance now to shifting to something that's more practical of, how you move your bones through space. So what are some things that you're doing now to be able to get around that language of all the verbs of tightening, squeezing, holding, pinching, whatever we use in our terminology?
Maybe we can layer them on. Squeeze your belly button to your. we can put them all together.
Squeeze
to your hollow spine.
To your left knee. There you go. That's it.
Well, honestly, I haven't cued that way in so long that for me to, like, sometimes when we make, our assignments in the classes and we're supposed to do things in the non-optimal way and then we do it in the optimal way, like cueing. And now I'd like you to do this thing and you use them on it and you just crack up and, it's hard to kind of sometimes to take it seriously. But the thing that I go back to is what is the shape that I want? That's where I tend to go. So if somebody is in a quadruped, hands and knees position, what is the shape that I want of the whole picture? And then what is the shape that I want in the places, in the body where I expect that there's going to be something going on that's not ideal? Because again, it's not going to be perfect. We're not going to say go to quadruped and go to neutral and everybody is going to just do that and be able to maintain it while they lift their arms and legs and do all the different things that we do. So I'm really after what's the one or two top common, and I hate to even say mistakes, it's like just common things that happen in the learning process. And I try to teach that so it never happens. That's my goal, my challenge with myself. So if I know the ribs are going to sag, what can I say that uses the bony anatomy and the shape? So I talk about the opening, the oval of the rib cage, and you guys have heard me say this 1,000 times, is over the oval opening of the pelvis, or they are aligned together because over and under, depending on if you're a headstand or standing up, is going to be different. So those two things are aligned together. So that's kind of my train of thought. I don't know, Nichole, what's yours?
Very similar. I like to use equipment a lot, or ground or something like that as frames of reference. So when you're prone, so when you're lying face down, before we even get into something like prone press up, which would be like our base level extension exercise, or any type of hip extension prone, just to do some pelvic tilts there and just let them explore and know what it feels like to have their pubic bone connected. To know that their ribs are touching the floor, because a lot of people aren't even thinking about their rib cage when they're face down. So what does it feel like? Can you feel the weight of your ribs? Okay, now we'll curl up. Can you ground through your low ribs in the top position? So you're in your extension. Can you press them into the mat? Okay, what does that feel like? Can you press your pubic bone into the mat too? Okay. Oh yeah, my abdominals just turned on. Yeah, they do that. Oh, my butt's working a little bit. Yeah, they'll do that too. And so using the floor, or if I'm in person, using my hands, can you push up into my hands? Okay, can you maintain that? Do you know what that feels like? So giving them something to push or pull into, I find that's really useful for me, just because since I think when you have a lot of mobility and stuff, sometimes you're a little more lost in space proprioceptively. So having more information is helpful. So I find tactile cues are really helpful for that. Also, language and teaching them about their joints, I use that a lot. So can you imagine your hip joint? Can you think of what that looks like? If we oversimplify it, and I'll use my hands, imagine this cup, and you have your femoral head in there. I'm obviously not going to go into the condyles or anything, but let's say you're doing scooter. So your front knee is bent can you imagine that the head of your femur is sinking back into the joint without moving your pelvis? Can you sink it back more and more and more, and all of a sudden their glutes turn on? So there are ways you can, if you understand, I think a lot of it also comes down to more experience is the more effective you'll be without cueing muscles. Because if you don't understand that lack of hip congruency and getting the weight in the right place on the foot is going to turn the glutes on when you're in that position, then you won't know how to cue it. So, and that comes with time, right? You watch people, I learned a lot from Amy Brockmeyer. I would go sit in on her sessions and I'd say, tell me everything you're doing. What is your thought process? Okay, why did you tell them that? Oh, it's because of this. Oh, okay, that makes sense. Okay, that didn't make sense actually, now that I'm thinking about it more. Okay, can you explain it to me further? Or then after the session, ask more questions. So when you get to have that greater understanding, then the understanding of the musculature, of how to get the muscles to fire without cueing the muscles, I think comes more naturally, because you have to understand why they're not firing. What's going on in their bony alignment that is causing them to have some deficiency? And that's what the normal person, a normal healthy person, I shouldn't say normal, that's what the healthy person who doesn't have like a neurological deficit, which would be a different situation, right? And that has its own things that you cue to help them feel their body a little better. But I think understanding anatomy helps a lot. So why functional anatomy, I should say.
Yeah, I want to add one quick thing to that. You made me think of another client that I worked with who was in a wheelchair in an automobile accident and didn't have any use of her legs, couldn't volitionally move her legs at all. And we were doing gyrotonic work, sitting, straddling the gyrotonic bench. So her legs were, she was sitting and her legs were open and her the lower leg was vertical. And we'd been doing it for a while. And it was really challenging for her because some of her trunk control, if you think about how much your legs assist you in controlling your body, especially if you're going to lean forward or lean way back. And those of you that know gyrotonic, just the arch and curl series, your arms are way, I'm going to lose my arms in the picture, way out in front of you. And if you didn't have your feet on the floor, it's really hard to support yourself only by pushing down with your arms. And one day I asked her, we had built a very good rapport, everything, there was probably nothing I could say that would bother her. And I said, would it be okay if I cued your legs the way that we cue the legs in gyrotonic work? And she said, absolutely, let's go for it. What do we have to lose? And I cued her legs, and I even put my hands on her thighs and moved her skin a little bit in the direction. She didn't move her legs at all, but I moved the skin, and that sends a message back to the nervous system. And her movement changed. I almost cried, and I'm almost getting teary now. Her movement changed so much. And we both had a moment of, that was a huge learning for me, because I can now, again, I'm not just going to do it. I'm still going to ask permission, but can I cue this the way I would cue it with somebody without this neurologic problem? And it was massive. I mean, it wasn't just a little thing, it was huge. And so I encourage you, if you can build that rapport with your clients, and it's kind of like going back to asking them, like, what did you notice? What did you feel? And she said, it was night and day difference, and gave me, some things that she was noticing. But yeah, thanks for that, Nichole.
A couple of things you both have said that sort of triggered some thoughts. One of the things, Nichole, when you said that you would ask for an explanation, it didn't make sense. A lot of times, those of us that have been explaining things our way for years, when we get questioned on some of those things, realize also that it doesn't make sense. It's just something we were taught 30 years ago, and it's stuck. And I think that a lot of times we have to continually ask ourselves, does this construct make sense of why we're doing what we're doing? Or is there a different correlation? Sometimes the exercise or the movement or the decision to do something actually worked well, but the rationale behind it was not the correct rationale. Let me give you an example of this. For years with McConnell taping, where we would tape the patella into a position trying to limit the symptoms of patellofemoral pain, right? So somebody would have so much pain in their patellofemoral they couldn't go up or down stairs. And so this technique was designed by Jenny McConnell. I think Jenny was from New Zealand, and it worked. We would use this tape, and we miraculously would have this, Pain, put the tape on, no pain, right? And everybody's going like, but it doesn't really make sense. You're going to tape the skin and you're going to change the alignment of the patellofemoral joint. And it was Christopher Powers out of USC that probably was the one that sort of answered a lot of our rationale of why it worked, because that was a big question for him in the research world. And what he discovered was that the tape pulling on the skin was uncomfortable when the knee would start to go into valgus. So we weren't pulling the kneecap back into alignment in the groove. What was happening is when the skin got pulled and it was uncomfortable, the body subconsciously corrected the strategy. Where did that correction happen? Was it the VMO that we were trying to strengthen with PNF patterns to the VMO muscle? Doing a little bit of hold that patella and pull up and relax and pull up and relax. It's like, no, not at all. What he discovered in the functional MRI was that it was the hip strategy that changed the rotation of the femur to avoid the tape pulling on the skin, that changed the neuromuscular pattern to use the lower extremity musculature correctly. You couldn't pinpoint it and say, well, I need to get this muscle to work. Or we would say that the VMO was 50% reduced in strength because the patella was tracking laterally. But that didn't make sense either, because neurologically, the lateralis, the intermedius, the VMO are all innervated by the same nerve, the femoral nerve. So the impulse is coming down. It's the same, a little bit delayed in time because of the length of nerve, but not enough to say that the VMO is misfiring. That doesn't happen. But pain was inhibiting the quads, and the hip rotators were not working properly. So this is what I'm saying is the construct often can be off, what we're using to explain why something works. We look at Pilates and we say, oh, Pilates must be a core strengthening exercise because it's fixing everybody's back pain. And we all know that core strengthening fixes back pain. And now, 20 years later, we look at it and we go, it's not the core strengthening. We know it's not the core. We know that volitional core strengthening doesn't work any better than anything else. And if anything, Letterman's work shows in a study of many papers, right? A systematic review, little brain fart there. A systematic review of many studies shows that if anything, it gets in the way and interferes with the quality of movement when you're doing voluntary contractions of TA and rectus and obliques and pelvic floor. So this is the kind of thing that's saying like, so what is it about Pilates that actually works? And we had done a study years ago where we looked at segmental displacement with students down at Loyola Marymount in 1996. And we had them doing a forward bend and looked at how many segments were actually displacing from T2 down to the pelvis. And we found basically people that did 5 Pilates reformer exercises, just doing Pilates exercises, had significantly better range of motion, better distribution, and reduced the stress in the L4, L5, L5S1 by as much as 50%. Just with a simple 5 exercise class. There was no talk about core control or strengthening during those 5 exercises. And likewise, Peggy Roller, Don Marie Ikes did a study looking at falls. And Peggy Roller is the expert in falls in the physical therapy world, where you're looking at all these, how do you perturb the vestibular system and the visual and the proprioceptive system. These people that had severe risk of falls did 12 weeks of Pilates at a Pilates studio with a Pilates teacher on a reformer. And they all came out of the high risk of falls group, and most of them stayed out for 6 months after. So we have to go back and think, is the construct that we use the right construct of what really is working in that positive movement experience? And I saw a comment from Giorgio and also from Sarah that both talked about spatial, moving the body in space. And both Nichole and Shelly have talked about this already, is that idea of having some anatomical reference is correct. And a lot of times what Eric does so nicely is he uses inanimate objects that do represent accurately the biomechanics and arthrokinematics and anatomy of the body. So when you think of a fan, or you think of an accordion, or you think of water flowing, you're actually integrating something that is accurate to our human anatomy or our movement form. So you're going to get better neuromuscular organization with a task in mind and an image that is going to represent more accurately your anatomy. And I think this is where our cueing has to continue to evolve to a place where we're flexible with it in a way that we're representing true anatomical organization without having to teach our patients all anatomy. But they do need to know enough anatomy to be able to appreciate moving the hip versus moving their lumbar spine. And that's what we're teaching them, is that internal awareness. These are super powerful. The question we were going to talk about, and we have a few minutes left. Again, we're not going to get, I want to get to the shoulder, because last time, we can do it real quick. Let's just do it. Melissa, pull up the slide and let's have everybody pick what they want to do, and we'll do it the last 5-6 minutes of this. When we talk about the abdominal wall, for example, the pelvis is a very complex, moving complex in itself, right? We'd say a joint complex. You have the sacroiliac, you have the pelvic femoral joint, right, with the hip joint. You have the L5, S1, L4, L5 above it. You have guy wires and fascia and contractile tissues, all different directions, from the lower extremity, from the back, from the gut, from the side, all working together to keep us upright in our ability to move. So when we think of being able to manage that, a single muscle contraction of the TA does not body movement make, right? It's not the end all. And so when we look at these types of questions that we're talking about, if you can think and gain, for example, I love to use a bowl of water when they're supine, or a bowl of soup, is I create the pelvis like it's a big bowl, and we're going to tilt the bowl forward and back or sideways, or we're going to do circumduction with the bowl, and watching people sort of struggle with that image. And an image of, like today, I used it with the diagonals, right? So take the pelvic towards the left foot and the right shoulder. One of the students says, I can do it great to my right side and left shoulder, but I can't do it to my left foot and right shoulder. And I said to them, isn't that interesting? That's the pattern of walking. So do you suffer from back pain or foot problems or anything else, that are along that line? And the individual said, yes, I do. Matter of fact, it's here. And I said, so if we can actually clean up that diagonal for you, I bet you would see improved movement and less discomfort in those areas, right? It was a huge gestalt for her. And now she's thinking like, I'm going to work on that diagonal. It's like, great observation. And now you have some tools to start working with it. Is it tightened hip flexor? Is it fascial restriction? Is it a joint impingement? I have no idea, right? That comes further down the road. But the movement pattern that we wanted is important. Let's show the slide and let's answer this in the last few minutes we have here. All right, look who wins. That was who was the last time too. We saw that come through. So rotator cuff injury. So I'm going to turn it over to Shelly or Nichole, whoever wants to go first. And you both have worked with people with shoulder injuries. And we're also going to bring some more case studies, not this next week, but starting in August. What would you say as far as some good advice or experience you've had in cueing people coming either off of a shoulder injury or maybe even a surgery in the post-rehabilitation aspect of shoulder impingement?
Well, I'll start. My go-to is making sure that they understand that their shoulder blade should be mobile. And one of the overheard, I don't hear it as much anymore, but just in a regular class, not even dealing with somebody with an injury. Oh, shoulders down, shoulders down. And basically what it tells me is I can't think of anything else to say. Shoulders down, tighten your abdominals. I have no connection to this movement or this person. And I remember talking with some of the physios in Australia, and they were actually seeing, and I'm sure other people were too, different cervical and brachial plexus nerve problems because people were they were pushing their shoulder down so much. And then with all those muscles engaged, I try to lift my arm and I'm going to move somewhere else that's not designed to move. I've lost the movement of my humerus in the socket. So one of the things that I really focus on is, and I don't use the exact number of degrees, but for you to move your arm up to at least shoulder height and a bit higher, the shoulder blade doesn't really have to do anything. It's when you start going up here, then the shoulder blade needs to move with the arm. And then again, you've got some space up at the top that it doesn't move too much. And that alone has been one of the things that I have found is hugely helpful. So the pull down with the tower bar where you get the assistance going down or the resistance going down, but the assistance coming up has been huge. So that's probably my go-to.
I would echo that, and also remembering that the scapular thoracic joint is two parts. It's the scapula and the thoracic spine. So especially if someone's coming off of an injury, you can spend a lot of time trying to move their thoracic spine, especially if you see that it is immobile, especially if you can see that the scapula isn't flush with the spine, you know that musculature under the scapula is not going to work optimally. So by working towards increasing the mobility of the spine, restoring, either if they're flat, restoring the curve, or if they're hyperkyphotic, getting them a little straighter, whatever it takes to increase that mobility is kind of this indirect pathway to help the shoulder function more optimally. And with the upward rotation of the scapula, I had this like big aha moment trying to get better at my handstands, and I'd be in my handstands and I would be dropping down. Like I would be here and I would just be sinking my whole body weight into my shoulders. And I was doing a downward facing dog one day and I was pushing the floor away and I was imagining the upward rotation. I thought, oh my gosh, I'm not doing this in my handstands. And all of a sudden my balance got better and everything kind of came together. I didn't have like the tension in my neck and my shoulders. But I think those two, it's like the scapula moves and it's connected to your spine, or it's connected to your rib cage really. And so.
No, I think you're both right on the money. And I love this part, it's like, one of the things we don't realize is that this was the scapula, and the scapula naturally has an elevation, depression, upward and downward rotation, protraction, retraction, but it doesn't have extension and it doesn't have rotation this way, right? And that's completely dependent upon the spine or the rib cage that it sits on. So a lot of times impingement is a result of lack of extension of that scapula. The scapula's job is to maintain congruency with the head of the humerus. So as soon as that scapula stops doing its job, then you're going to have impingement with overhead activity. That's where Shelly was talking about how the scapula has to move, or Nichole observing that the scapula is not flush with that rib cage, are both very good observations that the thoracic spine probably isn't doing its job. And there's a couple comments that came in. Linda Talcott said, if the shoulders are up to their ears when their arms are lifted, what cue would you use instead of shoulders down? And one possibility is thinking of first, where are they breathing from? That's one of the first things I want to know is, are they accessory breathers? Just shifting their breath down into their rib cage and their diaphragm can make a big difference in that idea. I'm not a big fan of saying, relax your shoulders, relax. It doesn't mean anything to them. But one thing I learned from Shelly is do the opposite. Can you bring your shoulders any closer to your ears? Can you bring it up higher, as hard as you can, lift it up. Now let go of it, right? Let it come back down. And it's still that process of going in the reverse psychology, like telling your kid, to do what you don't want them to do in a way that it doesn't sound fun, and then they choose to do the thing that you want them to do, right? So it's like you use reverse psychology. You're doing a little bit of reverse psychology with those muscles. So that's a good place to go. And
I also do let your scapular wings flare open more, because you can think of that upper medial border does drop down if you actually get the upward rotation, and that helps with that softness. So letting them, cueing them to find it. It's like, let your wings open, feel that opening here. And oftentimes that creates, do they reach more and open more here? That inner edge drops down and you'll see less bunching, I guess, or overwork.
Yeah. And I go back to also, there's a difference between kind of, none of the movements are pure, but a more pure elevation and depression, and elevation and squishing your neck. So I try to talk about, if you could get, if my hand's not going to show, never when I want it to show does it show. Could you pull your shoulder up to meet my hand, which is different than pulling my shoulder in to meet my neck. So if I see this, I may just say something basic like, okay, let's let the shoulders come down a little bit. I don't say press them down, but I let them down. And then I will do the contrast cueing of, can you even differentiate between your shoulders going more up as if they were going to go past your head versus going in toward your neck? Because that's, again, it's more different muscles. And that leads into that upward rotation that Nichole was talking about. So contrast cueing, you guys know, if you've worked with me before, give people all the options and then let them choose. What are all the possibilities? Okay, choose the one that makes the most sense. So
yeah. I used a great image yesterday with a patient. I said, as we get closer to 60 and 65, we start having all these wrinkles down here in our neck. I said, do you want to get rid of those wrinkles? She goes, yeah. I said, then, lengthen out of that space and, see if you can tighten up that skin a little bit in the front of your neck. And it was amazing that she was in this position when she came in. And when she left, she goes like, I don't have a double chin and I have some space and my shoulders feel better. And she wasn't holding her shoulders up anymore. It was just a visual image for her that I think motivated her because she was complaining about that, right? We do need to finish up here because I like to be on time and I really appreciate everybody's questions. What I'm taking away from today, on the next section that we do, and Melissa, you'll help me remind me of this, I'm going to go in pretty deep into the mechanics of thoracic spine and thoracic mobility and tools to be able to increase thoracic mobility. So I think that that's something where we get stuck quite often. We'll come back and hit that again. I know I've hit it in the past, maybe some rule of ribs that we can talk about to really give you some good imagery and tools that can help you with your clients in thoracic mobility. The other thing I was going to say, taken away from today, we talked a little bit about the hips. The things that typically in movement when we're getting stuck is going back to our down and dirty 3 areas of ankle dorsiflexion, hip extension and rotation, and thoracic mobility. So as we look at any of these pathologies, you'll hear me say it over and over again, like go back and look at the obvious things first before you go into anything too difficult and see how you can increase these other areas and if they decrease the load or the stress that your clients are feeling, and if they feel better when they have a little more ankle dorsiflexion, hip mobility, and thoracic mobility. Those are all things that help. There was a question about a course. I'm going to be doing my first live course here at the farm since COVID in October. It's going to be about critical reasoning. It's going to be a 3-day intensive full immersion course, learning the PAT, that's the Polestar assessment tool, learning the new principles of movement as we've talked about them and revamped them, going into the ICF model, the International Classification of Function and Disability, and looking at how we synthesize this information with live cases. So if this is something that's interesting to you, there's going to be limited space. It's going to be live here at the farm in North Carolina. Shelly will be at my side, I'm pretty sure, on this course. So we'll have a lot of fun looking at it, both from a Pilates teacher as well as a physical therapist or a chiropractor as well, or other movement practitioners, body workers, massage therapists that are also working in the Pilates arena. So our primary focus is for the Pilates practitioner in being able to assess, and as Giorgio talked about, creating that positive movement experience as our primary goal. Like how fast can we create these movement experiences because we have better assessment, we have better tools to be able to make sure that our Pilates whole body workouts are having more meaning and more outcome for our clients. And that's really what we're looking for. I hope today's been informative. I always learn a lot, and I'm glad that I could have Shelly and Nichole. Any last comments either of you have for the group?
no, just have a reason why you're doing things and then seek to understand if that reason is sound or not. So question other people, really politely question other people, very respectfully, and then also, periodically check in with what you're doing, and are you saying, the things that you really want to say? Does it make sense?
Thank you, Shelly. Thank you, Nichole. Appreciate you both, and appreciate you most of all for joining us and being with us from all around the world. And those of you that are joining later or remotely, or not remotely, you're all remotely, but those that join us asynchronously, that's the right term. We hope that you enjoy the content of today. Next webinar, we'll be focusing on thoracic science, and then we'll bring some case studies back, and we'll see if we can integrate some of these teaching skills and science back into our case study management. If you have a specific case that you would like to bring forward, please email Melissa or myself, Brent at Polestar Pilates. We'd love to be able to work through maybe one of your cases as a collective in the Polestar Pilates Hour. And until then, be safe. Keep your prayers for Cuba, what Cuba's going through right now, and other parts of the world that are still suffering or not as privileged as we often are not grateful enough for all the things we have in our countries. So have a great weekend, and we'll see you next week.